I just want to say welcome to everyone who's here. We're all delighted that you're here, and this is a subject that is of great interest, I think, to everyone my age and everyone down to our children and granddaughters. You're going to hear from 4 of Columbia's really distinguished faculty, and they're going to be speaking about cancer and what we should be doing about it, because 1 in 3 women are going to be diagnosed with cancer in their lifetime, which is sort of devastating for them and for their families, and something that if it's caught early can really be dealt with very well these days. They're going to share practical information about prevention and detection, and this again is where I do hope that we can circulate, that people can watch this again at another time, because I think it's of great interest, especially to younger women who are not able to be on this because of their working and picking up children from school and that sort of thing. Anyhow, I'm going to turn it over to Mary Dalton, our fearless leader, who never ceases to amaze me with what she does and with the absolutely extraordinary faculty that she continues to engage to help us all. Mary?
Great. Well, look, we're really happy to have everybody here today. And seeing as we're starting a little bit late, I'm just going to go right into it, because Sarah has already given you some of the data. And some of you who've been on our Zooms before know that each of our panelists will, some I'm sure you will know, will give a little bit of their own area of expertise, and then we'll open, after the 4 panelists speak, we'll open this for questions from you, and I want to give you time for that. So first up, we have our wonderful Jason Wright, Dr. Jason Wright, who's the chief of our GYN Oncology Division. And he's going to lay the foundation for us with new directions in breast and gynecologic cancer. He's a Saul Goldman professor, and he is also, in addition to being so prominent here at Columbia in our department and at the Cancer Center, he is the editor of our Green Journal, the major journal for practicing obstetrician gynecologists in the country. So he is responsible for disseminating knowledge and education to the majority of OBGYNs across the country. And we're very proud to have Jason on our faculty. And Jason is going to share for us new directions in preventing breast and gynecologic cancers.
Great. Thank you so much, Mary. Rachel, could we start the slides? Oh, perfect. So I want to thank you all for the opportunity to be here today. It's a real pleasure for me to be able to share some of the work that we're doing here at Columbia, and talk a little bit about some of the changing trends and some of the new developments that you'll see for breast and the gynecologic cancers. Next slide. So really, the purpose of my talk is just an introduction to the 3 speakers today, Dr. Trivedi, Dr. Ho, and Dr. Buckley. And I really just want to lay the foundation for what you'll hear in the next 20 minutes or so. And I think whenever we give talks about cancer, this is often a slide that we commonly start with, and that's just looking at the burden of cancer among women in the United States. So these are statistics that are from the American Cancer Society, and what they show in the figure on the left is the yearly number of new cases of cancer each year in the United States, and the middle panel is the number of women who unfortunately don't survive and who die from these cancers each year in the U.S. And we'll really talk about 3 cancers today: breast cancer, ovarian cancer, and uterine cancer. And I think you can really learn a lot about the major issues that are faced by these cancers just by looking at these slides. When you look at breast cancer, I think everyone on the call is probably very familiar with breast cancer. It's by far and away the most common cancer in women. You can see that nearly a third of new cancer cases each year are breast cancer, over 281,000 cases of breast cancer. I think what's been a remarkable success story for breast cancer over the last 20 years is that there are now wonderful treatments for breast cancer that are highly efficacious in being able to improve survival and improve the ability to cure breast cancer. And you can see for breast cancer that there are around breast cancer deaths only make up around 15% of the deaths from cancer. So many, many more women who are diagnosed with breast cancer survive their cancer and ultimately do well after diagnosis of breast cancer. The second cancer that we'll talk about is ovarian cancer. And when we think about ovarian cancer, when you look at the left-hand panel on this figure, ovarian cancer isn't even in the top 10 most common cancers in women. So ovarian cancer overall is a relatively rare cancer that affects women. But the major problem that we face with ovarian cancer is that to date, prevention and screening have been very, very poor. So for those women who are diagnosed with ovarian cancer, survival tends to be very limited. So you can see in the middle panel, ovarian cancer is actually the second most common cause of death from cancer in women each year, with 22,000 deaths each year related to ovarian cancer. And then the last cancer we'll talk about, Dr. Buckley will talk about uterine cancer. And, I think uterine cancer, whenever I talk to people about uterine cancer, I always make the comment that I think uterine cancer is really the cancer that, no one talks about, no one has heard about it. It's almost like time has left it behind. And you can see uterine cancer is actually the fourth most common cancer in women. There are over 66,000 cases of uterine cancer each year in the United States. Majority of women do well with the uterine cancer, but you can see the statistics in the middle portion of the slide. But I think what's really most dramatic about uterine cancer is there's really an epidemic of uterine cancer in the United States. Uterine cancer is actually the only cancer where both the incidence and the mortality are increasing year over year. So you can see in the panel on the right-hand side of the screen that each year there's a 2% increase in the number of cases of uterine cancer each year. So probably in the next 5 years, a woman will be as likely to have a diagnosis of uterine cancer as colon cancer, which receives much more attention and is talked about much more frequently. Next slide, please. So when we think about cancer, this is what we typically would think about in the pathway for cancer, both for the development of cancer and the way I think, we as clinicians think about the pathway in cancer and how we can improve outcomes and detect cancer early. So cancer is essentially just an overgrowth of cells that can occur anywhere in the body. And the little schematic at the top portion displays this, where on the left you have normal cells. And when a cancer develops, you typically have the development of precancerous cells. And if those cells go unchecked, they can multiply and grow, and they can ultimately turn cancerous or malignant, and they can start to invade the surrounding tissue. So really, I think our goal as oncologists is try to detect those abnormal cells when there's a precancerous state. So ideally, we can prevent cancer. And the second portion of this slide, I think, is really the paradigm that we would typically think about, where ideally we can prevent cancer, and we can come up with strategies, and whether it's dietary, whether it's interventions to try to prevent cancer before it develops. Number two, we can screen for cancer. So we can use tests like the pap smear, mammogram, colonoscopy to try to find cancer, ideally, again, the precancerous states before it develops into cancer. We can focus on early detection. So again, using those same tests to detect a cancer early before it's spread beyond whatever organ it started out as. And then new paradigms in treatment. So for those women who are diagnosed with cancer, actually improving the treatment and outcomes. So really, we certainly have a focus on the first two portions of this graph, but really I think a lot of the advances in cancer for those patients who do have cancer, I think we've really been successful in making cancer a chronic disease. So now there are new drugs, new treatments available, so patients can live a very long time with cancer, and we're able to keep the cancer under control and balance that with quality of life. Next slide, please. So I think when we think about cancer, there are two, large advances, two, I think, overarching themes in what's moved the needle forward in cancer over the last decade or decade and a half. And the first of those is really understanding the genetic basis of cancer. So understanding that the biology and the genetics of cancer. And you'll see this from both Dr. Trivedi and Dr. Ho's talk. Columbia, I think, has really been a leader in understanding the genetics of cancer and how to harness this information and to improve early detection and improve treatment for patients with cancer. So in the past, I think we kind of treated cancer as one disease. And now with the incorporation of better knowledge about the biology and the genetics of cancer, we can really understand an individual's particular cancer, and we can use that for the entire pathway that I showed you, from prevention and screening all the way to treatment. So we now use genetic information to try to identify those patients who are at the greatest risk for cancer, things like BRCA mutations and Lynch syndrome. We use genetic information now. Again, when I was a fellow, we essentially treated all endometrial cancer patients and all ovarian cancers the same way. We can now use this genetic information to prognosticate those patients who may benefit from more intensive therapy, and alternatively, those people who maybe don't need an intensive therapy. And then lastly, I think everyone has probably heard of the idea of precision medicine. Again, instead of giving everyone a given drug or a chemotherapy treatment, now we can use this genetic information to specifically target a cancer. Next slide. And the second, what I would argue is the second major advance in cancer care is our ability to harness big data. And I think you heard a little bit about the discussion earlier around AI, and I think AI is certainly one part of this. But over the last decade, the amount of data that's available and the technologies and the techniques we're able to harness this data and to be able to improve outcomes, I think it has really been incredible. And, this has been long an area of interest of mine, using big data to try to tailor care. But we really now have large-scale data sets, large amounts of data, where we can, for each patient, provide precision estimates of risk. We can use this data to classify and prognosticate cancer, and we can use big data to develop precision medicine therapies. So again, tailoring treatment based on genetics is one thing, but knowing a patient's family history, knowing drugs that they're on, knowing potential medical problems, taking all of this and again combining it into an individual strategy to either detect or reduce the risk of cancer, or alternatively improve the outcome of cancer. So I think you'll see in the next three talks, you'll see these two themes, both genetics and big data, that kind of weave through the picture of how our understanding of cancer has been advanced, and really, I think, highlight some of the things that we're doing at Columbia. So I'm going to turn it over to Dr. Trivedi next, who is going to speak about breast cancer. Thank you.
Thanks very much, Jason. And Dr. Trivedi is the co-director of our hereditary breast and ovarian cancer. She's in the Department of Medicine, and we collaborate so very well with her in her program. And she's going to talk about strategies for managing breast cancer risk. Meghna, thank you for being with us and all you do for our patients, and look forward to your talk.
Well, thank you guys so much for the invitation to speak today and for the kind introduction. If we could go to the next slide. So Dr. Wright already very nicely highlighted, where we are with breast cancer diagnoses. Unfortunately, the most common cancer diagnosis among women in the United States. And looking for the stats from the SEER database in 2023, almost 300,000 new cases of breast cancer. And I think a common question we often get asked is, well, why did I get this cancer? What's the reason that it happened? And I think, what we know is that the majority of breast cancers, about 70 to 80%, are sporadic or likely multifactorial in cause. But there are about 5 to 10% of breast cancers that are due to a hereditary cause, again, going back to this idea of a genetic predisposition. And so it's becoming increasingly important in breast cancer treatment and risk management to understand this underlying genetic cause. Can go to the next slide. So what would qualify someone as being high risk for breast cancer? So, in the general population, the common quote that we have for risk of breast cancer is 1 in 8 women will develop breast cancer over the course of their lifetime. So about 12 to 13% overall. For the purposes of defining what is high risk for developing breast cancer, we define it as a 5-year risk of developing breast cancer greater than 1.67%, and also a lifetime risk, meaning through the age of 90, of developing breast cancer of 20% or higher. So where do those numbers come from? How is this risk estimated? So we luckily have several different risk models, including the Gale risk model, the Tyrer-Cuzick or IBIS model. There are several different models that input a lot of the risk factor information that's individualized or unique to the patient and can put an output of this 5, 10, or lifetime, 5-year, 10-year, or lifetime risk of developing breast cancer. Of course, there are individuals who also have this underlying genetic susceptibility due to having a inherited genetic pathogenic variant in a gene that's related to a cancer predisposition syndrome. And then in some women who have atypical breast lesions or benign breast disease, such as atypical hyperplasia, ductal hyperplasia, atypical lobular hyperplasia, these findings can also indicate an increased risk for developing breast cancer, though they are benign lesions. Next slide. So as we mentioned, this idea of genetic predisposition, there are several different genes that are associated with an increased risk in breast cancer. And by far the most common hereditary breast cancer syndrome is due to the BRCA1 and BRCA2 genes. And having a pathogenic variant or an abnormal variant in these genes is associated with a 60 to 80% lifetime risk of developing breast cancer, and is associated with several other cancers, such as ovarian cancer, which we'll be hearing about next, pancreas cancer, melanoma, prostate cancer. So understanding whether someone carries these pathogenic variants in these genes is really important. Again, not just for breast cancer risk management, but for also other genes. Additionally, with advances in technology and genetics profiling, we've also learned several other genes that are associated with increased breast cancer risk. And these can be easily found by doing multi-gene panel testing. And so we have high penetrance genes, meaning genes that confer, a greater than 40% lifetime risk of developing breast cancer. These include genes like TP53, which is also known as Li-Fraumeni syndrome, P10, STK11, CDH1, and PALB2. And we also have more moderate penetrance genes, which confer about a 20 to 40% lifetime risk of developing breast cancer. And these genes include ATM, BARD1, CHEK2, NF1, and RAD51C and D. And based on carrying, there are guidelines that are out there that help us understand what's the best way to manage the risk in individuals that carry these pathogenic variants in these genes. Go to the next slide. So I'll finally just end on, what are the things that we can do to manage our breast cancer risk? I think there are certain things that we are in control of and others that we don't have control of. I think lifestyle changes are a big issue, again, not just for breast cancer risk management, but for all cancer risk management, as well as our own cardiovascular health. And this involves doing things such as staying active, exercising at least 30 minutes a day, 5 days a week, eating a well-balanced, healthy diet, making sure that we minimize our alcohol intake. I think these are all important lifestyle changes that we can make, again, not just to reduce our breast cancer risk, but also our overall health. Screening is also very important from an early detection standpoint, as Dr. Wright pointed out. And so we have many different modalities, but also very effective modalities for screening for breast cancer. And these include mammogram, breast ultrasound, and breast MRI. And I think making sure that each individual's risk, personal risk of developing breast cancer is assessed, and making sure that their screening protocol addresses that risk is really important. So not everyone needs a breast MRI, but there are certainly a population of women that have high enough risks that warrant using a breast MRI as part of their routine screening. Risk-reducing surgeries is something we hear about both from a breast perspective as well as from a gynonc perspective. And so having a risk-reducing mastectomy can significantly increase the risk of developing breast cancer by over 90%. However, it is reserved for those at the highest risk of developing breast cancer. So it's something that could be considered in BRCA1 or BRCA2, as well as some of these other high penetrance genes. And finally, the use of chemoprevention, or using a medication to try and help reduce the risk of developing breast cancer. We have drugs, anti-estrogen drugs, that we commonly use in the treatment of hormone receptor positive breast cancer. And these drugs can also be used for the reducing the risk of developing breast cancer by about 50 to 65%. And there's been a lot of research looking into this, and these studies have been performed for decades with lots of follow-up, and even more recently looking at more novel ways of dosing these anti-estrogen therapies in order to maximize risk reduction and minimize toxicity. We also have ongoing trials here at Columbia looking at different types of prevention. In particular, we have a trial specifically for BRCA1 carriers looking at using a drug called denosumab, which is a commonly used osteoporosis medication, and using it in BRCA1 carriers to see if it can help reduce the risk of developing breast cancer. So I think all of these are areas of active research. We already have a lot of data, but learning how to individualize these risk management strategies and making sure that they reach the people that need them, I think is high priority for us. That's my last slide. Dalton, I think you're muted.
So June, are you going to speak?
I am.
Oh, maybe I introduced you and I was on mute. Oh, I'm sorry. I apologize. June is our wonderful person in our GYN department in Jason's division, who is going to talk to us about strategies to diminish risks of ovarian cancer. So June, sorry, this is my second time introducing you. First time on mute. I apologize.
No problem at all. Hi, everyone. Let me know if you can't hear me well. But I'd like to extend my gratitude to Dr. Dalton for the kind introduction and an invitation to speak to all of you again today. Since having the privilege of being a GYN oncologist and to take care of many women battling ovarian cancer, these interactions really shape my dedication to want to improve their cancer outcomes. And dovetailing on that is also an interest to help women who don't have cancer identify strategies to diminish their risk of developing ovarian cancer. Next slide, please. Great. So one unique aspect of ovarian cancer that I just want to press today is its strong hereditary component. 1 out of every 4 to 5 women with the cancer diagnosis have actually an underlying genetic predisposition. And that is important because while we've made remarkable strides in cancer treatment by ways of drug discovery, which Jason mentioned previously, and yes, the 5-year survival rate have doubled over the last 4 decades for women living with ovarian cancer, but the cure rate remains dishearteningly low, under 15%. And that is predominantly due to the absence of effective screening strategies. So unlike the proven effectiveness of mammograms for the breast and pap smears for cervix that can detect pre-cancer lesions and even early cancers, the combination of what we typically recommend of the pelvic sonogram and a blood testing called CA-125, or as many of you may know, notoriously non-specific. And that actually led to its recent discommendation, if that is a word, from the NCCN guideline for use for screening, even in high-risk individuals. And next slide, please. So with the absence of effective screening, it becomes even more critical to understand our own risk for ovarian cancer. And aside from age, which affects all of us, there are really 2 primary risk buckets for ovarian cancer. First is the presence of hereditary genetic mutations, with BRCA1 and 2 genes being, yes, the predominant contributors for hereditary cancers. And we will discuss in the next slide how to leverage that knowledge into prevention strategies. But secondly, it's the number of uninterrupted ovulatory cycles that contributes to cancer development across a woman's lifetime. And that shed light on why factors such as month of breastfeeding and use of oral contraceptives like birth control pills are considered to be protective. And an interesting protective measure that doesn't actually fall into either of these buckets is tubal ligation. Yeah. So we now know that the majority of the most common and deadly type of aggressive ovarian cancer actually originates from the fimbriae of the fallopian tube itself. And so tying the fallopian tubes or tubal ligation or removing the fallopian tube in their entirety, or called a salpingectomy, can actually decrease one's risk for ovarian cancer by up to 65%. And that is huge. So by understanding these risk factors, we can position ourselves better on the front line of prevention. Next slide, please. Cancer genetic testing, I think, is the most important way to fully ascertain our own risk. Comprehensive panel testing, which basically means testing for genes beyond just BRCA1 or 2, can uncover an additional up to 14% of hereditary ovarian cancer cases. And it can, as you can imagine, inform other cancer risk as well. Cancer from the GI tract, cancer from the uterus, cancer from the breast. And this is rapidly becoming the standard of care. For those women who are identified as having high risk through testing, we can then individualize and recommend a range of cancer reduction strategies. As Dr. Trivedi has mentioned before, for the breast cancer, very similarly, we have surgical procedures to prevent ovarian cancer by ways of removing the fallopian tube and or removing the tube with the ovary. Chemo prevention strategies, and the most common strategy actually is taking the birth control pills. And for patients, more importantly, with known genetic mutations, it becomes even more critical. Novel cancer therapies such as PARP inhibitors and other targeted therapies have really dramatically changed and improved the outcome of women with hereditary ovarian cancer. Next slide, please. And so this is my shameless plug, but we have a multidisciplinary center for hereditary breast and ovarian cancer at Columbia with the support of Dr. Dalton and Dr. Wright. Our team comprised of a team of specialists from breast oncology, breast surgery, GYN oncology, and importantly, genetic counselors. We can tailor cancer risk assessment and management plans for every patient that we see. In this initiative, a very good collaborative experience with Dr. Trivedi has really been a personal highlight of my career. And it's been extremely rewarding to see it grow. Since 2019, we've seen and counseled almost 800 patients and tested over 450 patients through this program alone. So with a proactive approach to understanding and ascertaining our own cancer genetic risk, which again is the biggest risk factor for developing ovarian cancer, I am optimistic about our potential to significantly diminish, if not ultimately eradicate, a diagnosis of hereditary ovarian cancer. And that's the end of my talk. Thank you.
June, thanks very much. And thanks for your leadership in this area with Meghna. We're very, very, very proud of you. And next, I'm very happy to have Dr. Alex Buckley present to us on uterine cancer. Last but not least, Alex. And Alex trained here with us as a fellow and then left us to join the faculty at another program, and we were absolutely thrilled to recruit him back just a year ago. So Alex, thank you for coming back to us, coming home, and we look forward to your talk.
Thank you very much for your kind words. It was truly coming back home. Thank you everyone for trying to pay attention to this large amount of information in such a short period of time. Can we please move to the next slide? We can go one back. Thank you. I'm here to talk to you about uterine cancer today. It's such a large topic as every other topic. So I wanted to focus on something that Dr. Wright mentioned in his introduction. Uterine cancer, despite not being as quote unquote deadly as we say ovarian cancer is, it is an epidemic in the country. So I want to focus a little bit of this presentation on that. We can go to the next slide, please. The graph on your probably left shows how the incidence of new endometrial cancers has been steadily going up in the United States. About 15 years ago, we expected about 40,000 new cases of endometrial cancer in a year. And then about 5 years ago, that number raised to close to 60,000 cases. And for 2023, we are estimating already over 60,000 cases a year. This, as Dr. Wright showed in a previous slide, is the cancer with the highest growth in incidence, which is of much concern. Something also that is interesting about, endometrial cancer and its presentation is that this incidence is growing, but it's also growing disproportionately in non-Hispanic Black patients and also other minority groups like Hispanics and Asian population. We can go to the next slide. So what are risk factors for endometrial cancer? Just like other cancers, there is a genetic component, and about 10% of endometrial cancer are related to genetic inheritance. And the most popular syndromes, or the most known syndromes, are Lynch syndrome and the Cowden syndrome. But then most of endometrial cancers arise from an unopposed exposure to estrogen. So anything that would make a woman produce estrogen outside of a cycle will stimulate the endometrium, which is the lining of the uterus, and eventually lead to a precancerous lesion that can eventually become a cancer. In a regular cycle before menopause, women have a higher level of estrogen during their cycle. When ovulation happens after 2 weeks, this level of estrogen drops, and eventually the period comes. So estrogen stimulates the endometrium, drops, and this endometrium, this lining of the uterus, is shed and presents as the period. So anything that prevents this cycle of estrogen will increase the risk of endometrial cancer. I mentioned that ovulation is the signal to decrease estrogen. So women that don't ovulate, like women that have PCOS, for example, polycystic ovarian syndrome, will be at increased risk for endometrial cancer. And there's other reasons not to ovulate. After menopause, which is the group of women that are at higher risk for endometrial cancer, where is that estrogen coming from? In the United States, as the epidemic of obesity has increased, we see how not truly parallel, but both curves of the incidence of obesity and endometrial cancer are rising together. And that is because in fat tissue, we produce estrogen. And so because there is no cycling like there is in the ovary, these steady high levels of estrogen produced by the fat will stimulate the endometrium, and over the course of years can lead to endometrial cancer as well. And then there is, medications like hormonal replacement therapy, tamoxifen, and some tumors that secrete estrogen that can predispose to endometrial cancer. Some of the protective factors are pregnancy and breastfeeding, because estrogen is going to stay low during that time. Hormonal contraceptive that counterbalance estrogen, physical activity, diet, and weight loss will prevent high levels of estrogen. And in italic, I added smoking. Obviously, smoking is not something that is encouraged, but it accelerates the metabolism of estrogen and drops the risk of endometrial cancer as well. We can go to the next slide. Fortunately, within the bad news of having endometrial cancer, it presents with symptoms at an early stage. So women with abnormal uterine bleeding, when they are during their premenopause phase, have this presenting symptom that might lead to a workup and early diagnosis of endometrial cancer or pre-cancer lesions. And then after menopause, any amount of bleeding is considered abnormal and needs to be worked up. It is a very common misconception when we see patients in the office that even a little bit of bleeding that comes and never comes back is normal. And that sometimes can be the reason for delay of workup and treatment for endometrial cancer. So one message from me is that any bleeding, as little as it is after menopause, is abnormal and requires medical attention. We can go to the next slide. When it comes to endometrial cancer screening and prevention, truly there is no useful screening tool for the general population. What a screening tool or a screening test tries to do is to prevent the diagnosis of cancer by finding a precancerous lesion. There is no test that is, cost effective to try to prevent endometrial cancer. That being said, for the populations at higher risk that have a genetic predisposition, we do offer screening with endometrial sampling, endometrial biopsies once a year, starting at the age of 30 or 35, and yearly pelvic ultrasounds. Truly, what needs to be done is prevention. And so lifestyle changes with weight loss, exercise is important. For patients that have a genetic predisposition, chemo prevention, meaning medication, can prevent the production of estrogen and can prevent the development of endometrial cancer. And then for patients that, again, have an hereditary predisposition like Lynch syndrome, risk-reducing surgery is offered to these patients once they complete fertility. And risk-reducing surgery for Lynch syndrome includes not only removing the uterus to prevent endometrial cancer, but also bilateral salpingo oophorectomies can be offered because the risk of ovarian cancer is also increased with this syndrome. Next, do I have a next slide? Yeah, this is not so much, of course, screening and prevention, but these two clinical trials have been the highlight of our year as GYN oncologists, where we have, seen a dramatic improvement in patients' response and outcomes with the incorporation of immunotherapy to their treatments. These are two very, very large trials, multinational and European trial, that have shown a significant improvement in patients' outcomes with immunotherapy. And just, as a general concept of what immunotherapy does, on this slide, you can see on the left side, cancer cells have this ability to shut down and turn off our immune system. And then our own immune system is not able to kill the cancer. So what these drugs are doing is interrupting this communication between the cancer and the immune system so that the immune system can turn on again and now recognize again this cancer and kill it and destroy it like it's supposed to. So these are very exciting strategies to treat cancer in general, not just endometrial cancer, that have been a game changer in what we do. And I think that's probably my last slide.
That was the last slide.
Thank you very much.
That's great, Alex. Thanks very much. And it's hard for me to believe that all of you kept to your time and we got back on track in terms of the time, having started a couple of minutes late with our Zoom issues. So you can see we have great division of GYN oncology led by Jason. And I now open this for questions. If any of you have questions from the Zoom, I'm looking in the chat, and I'm sure all of our team would be willing to answer questions for you. Everyone is quiet so far. Could I ask you, Meghna, then, just to start it off, what is the newest thing in the treatment of breast cancer?
Great question. I think as Dr. Wright alluded to in the beginning, we're really trying to implement this idea of precision medicine, or I guess more broadly, individualized treatment for breast cancer. And so, I think in the past, the thought was always more is better, bigger surgeries, more chemo. I think what we're trying to understand, or what we are starting to understand, is that each individual is different. And that one strategy, a one-size-fits-all strategy, may not be the best strategy for everyone. So how can we figure out who needs more and who needs less? So this idea of de-escalating these kind of very big treatments for those individuals who may not get significant benefit from lots of surgery and lots of chemo. And on the other hand, doing appropriately escalated therapy for those who are at highest risk of recurrence and advancing disease. And so, we see this with the use of genomic, risk prediction. So in breast cancer, there's a assay that we send called the Oncotype. And in 2018, when the kind of landmark trial for this study was presented, we learned that there was a large percentage of women with lymph node negative breast cancer that could skip chemotherapy and be do just as well as as women who got chemotherapy with hormone therapy alone. I think another approach that we're using a lot in breast cancer, particularly early stage breast cancer, is the use of neoadjuvant therapy, or giving treatment before going to surgery, so that way we can assess the biology of the tumor itself and try and make treatment decisions based on how well the tumor is responding to the therapy. We have a novel trial here at Columbia that I'm the site PI for, called the I-SPY2 trial, which is actually it's an adaptive randomization trial, which is looking at novel drugs that often have FDA approval in other settings, but some of which are very early in development, and trying to apply them early on in breast cancer to try and see, can we get good responses, which is measured by having a pathologic complete response, meaning the tumor is completely gone by the time of surgery. And through this kind of stepwise study, where you have 3 different blocks, block A, block B, and block C, we get the novel therapies in block A. And if there's an excellent treatment, some patients are actually able to skip and avoid some of the standard therapy and go straight to surgery. And those individuals who don't respond as well as we hope, they have the option of going on to block B, which is a more standard chemotherapy approach. And finally, if there's not enough response, they finish out another 8 weeks of an anthracycline-based regimen. And so, again, the idea, kind of what we're seeing now in breast cancer risk management, or breast cancer treatment and management, is, can we really individualize the treatment in order to maximize the efficacy as well as minimize the toxicity?
Thanks very much, Meghna. I don't see any questions in the chat, so...
I've got one.
Oh, you've got one, Sarah. Good.
I'm not good using chat.
Okay.
I just want to ask, anyone can answer this. When should women start to get mammograms, and can you ever stop? Like, when I'm my age, I'm in my 80s, early 80s, can I stop getting mammograms, or do I keep getting them? When do you start all these things, and when do you stop?
That's a great question. And I think this is another, this is, again, I think another thing that is very individualized. It's not a one size fits all. I think that there is also, we see in the media some controversy about when should women be starting mammograms. I think that most guidelines would say for the average risk woman to begin getting mammograms somewhere between the age of 40 and 50. In someone who has a hereditary predisposition or is high risk based on other factors such as family history or other personal factors, we can start screening as early as age 25 using a breast MRI and adding in a mammogram at age 30. The question of when to stop screening is also a really important question. And I think this is something where all the guidelines recommend, a shared decision-making process with your physician. And so one person at the age of 75 may be acting like a typical 50-year-old, in which case, it's reasonable to continue screening. And I think that the question I always ask my patients who are approaching the age where they may want to consider stopping screening is, if we found something on the screening imaging, would you want to do anything about it, right? So would you want to go through with a biopsy, potential surgery, potential treatment? I think that's an important factor to take into place. If not someone who wants to act on a screening, then perhaps it's time to stop for whatever that reason may be that you don't want to act on a screening. But I don't think there is a cutoff, a strict cutoff for any age. I think it's really a decision that has to be made between the patient and their physician.
So, Sarah, you can never stop because you're like a 50-year-old, I would say.
Can I ask, always. Is cancer of the uterus genetic or not?
Alex, we'll have you answer that, I think.
Yes, there is a component of genetic cases. There is, the most popular syndrome is called Lynch syndrome, that increases the susceptibility of endometrial cancer and colon cancer primarily, some other cancers as well. Initially, this syndrome was recognized in colon cancer patients. But now, over the course of the years, we've recognized that endometrial cancer can be the presenting cancer for these patients. That leads to the diagnosis of Lynch syndrome. and allows prevention in other areas. These patients need more frequent colonoscopies, for example, endoscopies as well. So yeah, there is a component.
When should people start doing colonoscopies, especially if there is, you know, if some mother or grandmother had a cancer of the uterus?
If a family member had endometrial cancer or uterine cancer, independently from Lynch syndrome, it doesn't change the general recommendations of getting a colonoscopy. And, you know, the age at which to start colonoscopies is changing, was recently dropped. It used to be 50 years old, is now, 45 years old. And it also, as Dr. Trivedi mentioned, it's going to depend also on your family history and individualized factors, risk factors.
Thank you very much. That's very useful.
Thanks very much. Any questions? Well, then I have one for June, and it's always kind of mystified me as to why the early symptoms of ovarian cancer are so often overlooked, and how could we increase the awareness?
Yeah, no, that's a great question. I think as you were saying, the early symptoms of ovarian cancer, they do exist. Ovarian cancer used to be thought of as a silent killer, but I think more and more that notion, that term is going out of fashion, thank goodness, because largely of a lot of these are educational campaigns. But the problem is that these symptoms can be subtle, and they can often mimic common problems that average woman goes through on a daily basis or a monthly basis, especially if we're premenopausal. So things like bloating, pelvic discomfort, changing bowel habits. Can you imagine? And so as a result, many women kind of dismiss these symptoms, or, more importantly, there's a notion of gaslighting, these symptoms by their healthcare providers, frankly, because yes, there are other conditions such as irritable bowel syndrome, endometriosis, or just dysmenorrhea or menstrual irregularities that can also present similarly the same way. But I do believe in kind of talking to patients, all women, and actually all healthcare providers, about what's called the Ovarian Cancer Symptoms Index. And that is a symptom index that's first characterized by, I believe, Dr. Barbara Goff from the University of Washington in Seattle. And she talked about, bloating, again, pelvic discomfort, changes in GU habits, constipation, etc., and just changes in weight. And so this constellation of symptoms, especially if they happen often, if you happen to have or experience pelvic bloating a couple times and it goes away, I tell my patients that it's okay, we'll just monitor them. But if these things keep on happening more than once every 3 or 4 days or so, but then in thinking back to your own medical history, if you feel like these are some of the new onset of these symptoms within the last year or so, then these are the things that you should really kind of advocate and talk to your doctors about. I mean, many of us have heard or share patients who shared stories about how they do have symptoms in thinking back that were dismissed earlier. And maybe if they had talked to their symptoms with their providers a little bit earlier, or had their stories be taken seriously and set up on their diagnostic path a little bit earlier, that they may have made a difference in their cancer outcome. So I think that we need to educate and raise awareness, not only amongst patients, but also amongst healthcare professionals.
Thanks very much, June. That's great. I've known about those symptomatology index from Barbara Goff, and it's always good to be reminded. Thank you. I know that Estelle had a question, and I didn't see your hand up, Estelle. I apologize.
Thank you for the wonderful talks. I was just wondering if we could clarify when to get a pelvic sonogram. It seems it's not useful anymore for ovarian cancer detection. Is it still useful then for uterine? Or I would love to hear that clarified.
I'm happy to get that started, and Alex and Jason can chime in if needed. So it is mystifying that pelvic sonogram is actually not even recommended for routine screening for high-risk women, even those women with BRCA1 and BRCA mutations. And I think that really just speaks to the non-specific nature of the findings, if you know what I mean. But I also think that it's important to keep in mind that, yes, it's not necessarily routinely recommended, but if you have symptoms, and that is what I always tell my patients, if something is, you know your baseline, your body the best. So if you feel like something is off, any bloating, any pelvic pain, any changes to your symptomatology, that is absolutely a time to bring those symptoms up to your gynecologist, or even your primary care provider, to get an assessment. It is a very good way to just get a landscape access of your pelvic anatomy, your ovaries, your uterus, your cervix. So while it may not be so great and specific in diagnosing precancer lesions from ovarian cancer per se, but with any symptoms, that is definitely, an opportunity to get that test.
Thank you.
If I may add to that, the idea of doing a screening test is early detection with the hope of having an impact on the outcomes or results of the treatment of certain pathology or disease. And as opposed to breast cancer, where we know that mammograms do have an impact on the treatment of women with breast cancer, we have not demonstrated that with ultrasounds when it comes to ovarian or endometrial cancer. So doing these yearly screening tests won't necessarily have an advantage for the patient. As Dr. Ho mentioned, they're more useful when they're led by symptoms or some discomfort. Now, for endometrial cancer specifically, patients that do have Lynch syndrome, we do recommend yearly ultrasounds because it does seem to have an impact on early detection and cure rate and outcomes for those patients. The data is not large when it comes to scientific data, but it seems to trend towards a benefit of yearly ultrasounds for those patients.
Thank you.
And if I
Alex,
could just dovetail
that's
on
very
that.
clear. Sorry, June, I interrupted you. I apologize.
No, it's okay. I was just getting excited about this topic. If I could just dovetail on that, I think the holy grail for ovarian cancer is really early detection and early diagnosis, So there are very promising international trials, a series of research studies actually, that are focusing on developing a blood test to detect multiple types of cancer at early stages by analyzing cell-free DNA. So I know that we've talked about these blood tests for a while, and this is not in any way equivalent of CA-125s, but I think that in hearing hearing updates from some of these research, I think that we're getting close, and it's kind of circling back to what Dr. Wright was saying. There's an international research push towards precision medicine, and shifting the paradigm from broad-based screening, which is ultrasound and a non-specific CA-125, to something that's way more individualized and targeted.
I know you're very passionate about things, June, so it's wonderful to be able to share that passion and the passion of all of our team here this afternoon. And as I think we're very close to the end of the hour, but as we started a little bit late, I would hope that you'd indulge me, and I will give the last few minutes to Dr. Wright, where I'm going to ask him, where will we be in 5 years? Where can we look forward to your great division in 5 years, and what additional things you'll be able to do?
Yeah, I think the next 5 to 10 years are going to be really transformational in cancer care. I will make a big picture prediction and then one smaller for the GYN cancers. I think for cancer overall, what you'll see in the next 5 to 10 years, instead of thinking of a breast cancer and ovarian cancer, we're going to be able to take all of the precision information that we have about the genetics and the things from big data to look at specific molecular profiles, and for each patient be able to really design an individualized, personalized, targeted therapeutic approach that I think is going to not only extend survival and increase the chance of cure for cancer, I think it's also going to reduce the side effects from cancer. I think, from the GYN cancers, I think as you've heard from both June and Alex, I think we've really suffered for both ovarian and uterine cancer, and we really don't have good screening and prevention. I think within the next 5 years, we're going to have screening tests and prevention for both ovarian cancer and uterine cancer. June made a comment that we now realize that most of what we think of as ovarian cancer often starts out in the fallopian tube. There's now a big trend nationally to start removing the fallopian tubes and do what's called a salpingectomy. So we've done some work here for women who are having their gallbladder removed. At the same time, taking out the fallopian tubes, something that takes 10 or 15 minutes, could reduce the number of ovarian cancers by over 1,000 cases in the U.S. each year. So I think it's simple things. It's taking all the things that we have for preventive strategies. I think for endometrial cancer, we'll have a screening test with some of the new things also that June talked about with blood tests and being able to collect cells from the cervix. So I think cancer, the face of cancer is going to change. And I think in GYN cancers, we're really going to finally have better screening and prevention strategies for our cancers. So I think I think we're going to be in a lot better place if we all get together at 4:00 for one of these in 5 years from now.
Well, hopefully we'll get together much before 5 years. It's been too long since we were all together, and this was wonderful and something that I think we're all get nervous about and wonder what kind of testing we should have. And as Sarah said, when do we start? When do we finish? And all of those questions that everyone had this evening was so pertinent. And I think you can see why we're very proud to have such great doctors here doing cancer care, both identification, treatment, and amelioration of patients with cancer. So, and Meghna, we're very, very happy to work with the Department of Medicine as well. So thank you all very much. We're 5:02, not too bad. And we'll be happy to share the Zoom with everybody who couldn't make it. We've tried to stick to our times, and Maureen or Rachel, are we okay? Do we need to do anything else before we sign off?
I don't think so. Thank you so much for a wonderful meeting. This was so informative.
Thank you. Thank you all. It's lovely to see all of you on the Zoom, and can't wait to see you all in person as soon as we can. Thanks very much.